Right, evening everybody. Welcome to the Faculty of Emergency Leader Programme lecture this evening. And this evening we've got Rachel Torrington from Gloucestershire, who's going to talk to us about how they support their high intensity use patients. Gloucestershire do something a bit different, which Rachel will describe to us, but they make use of social prescribers, and they have their HIU team is run from safeguarding. So Rachel, please introduce yourself and off you go. And just tell me when you need the slides moved on and I will oblige.
That's lovely. Thank you, Jeanette. So hi, as Jeanette said, my name is Rachel Torrington and I'm the High Intensity Use Coordinator at Gloucestershire Hospitals NHS Trust. And I'm here to talk to you about, as Jeanette said, HIU patients and the process we use and a bit more about national things going on around HIU patients. First slide then, please, Jeanette.
This is the webinar information.
Yeah. Thank you.
I think everybody knows that now, so we'll give them a couple of seconds to read it.
Brilliant, thank you.
And then we'll move on.
So it says here, let's recap on HIU patients. Well, high intensity use patients have been called all sorts of things over the years by us healthcare professionals. Frequent flyer, we've got hospital hoppers. Lately it's been high intensity users, but now we call them high intensity use, as user denotes a connotation to substance misuse. So NHS England has specified that we call them high intensity use patients. These things keep changing and we have to keep changing our systems to marry up. So we looked at the definitions. So the Royal College of Emergency Medicine specify that an HIU patient is a patient that attends ED more than 5 times in a year. So as you can imagine, if you look at all your patients in your ED department, just to say to you that we have got, after a project that we did a few years ago, well 2 years ago, we've got roughly 1,400 patients that meet this criteria. Every month we ran the report, so trying to manage those would be nigh on impossible. And you get your patients that are attending with post-op problems, or they're coming for dressings, or they're unwell and they've had a period where they had to come back in. So yeah, 5 times actually to us A&E lot isn't actually that much, is it? And we say that a super user is somebody that comes in 20 times or more in a month. Now, RChem don't specify what a super user is, but we say 20 times, and this kind of joins up with other hospitals in the southwest area that we did a project with a couple of years ago, which I'll talk about in a bit. And of course, if patients are coming into A&E, they're using all health services, including 111, GP, complex care teams, community nurses, mental health contacts in the community, voluntary organisations as well on top of that. So the list is endless. If we're seeing them, 9.9 out of 10, everybody else is seeing these patients as well. So it's really important that we work together. And of course, RChem specified that in 2021. It's not changed, and there is quite a lot from RChem about high intensity use patients. Next slide, please, Jeanette. So we talk about frequency, hence the connotation frequent flyers that we used to use. But of course, it's not just about how often they come, it's about the impact they have when they come. So as it says at the top there as well, if we see them in ED, everybody else is going to see them across all healthcare settings. Many of us, even who don't work in ED, have come across these patients, whether it's outpatients, on the wards, in the community. We've all come across these high intensity use patients in the past. So we talk about impact. Actually, in fact, we used to call them high impact users as well. So that's another terminology that we use for these patients. It's not just about the frequency, it's about the impact or the complexity or the level of healthcare they need. So we might get our patients that come in every day because they've got mental health issues, We might get our patients that come in once or twice a year, but are incredibly complex and hard to manage when they do come in. We all know these patients. We can get the really complex medical patients. We can get the abusive patients. We can get the patients that are drug seeking. So when we use the word impact, it can cover a multitude of things that we've all come across in ED. So as it says there, it's just a multidisciplinary services involved, or a combination of these. So it's all these people coming together to manage these patients that are accessing all areas of healthcare. And of course, as I'll talk about later, we talk about health inequalities. Many of our patients come from areas of health inequalities, and this vastly affects them eventually turning into an HIU patient, or they're more at risk of being an HIU patient and attending ED. So again, I will talk later, it's really important about us identifying these patients early on and trying to manage them. Next slide, please, Jeanette. So there's a lot at the moment going on with high intensity use patients in the country, but I wanted to talk to you about NHS Right Care. Now, NHS Right Care is designed by a lovely lady who sits at the top of NHS England for HIU patients, and her name is Rhiannon Monteith. So she's been hugely involved in NHS Right Care. So just to say that NHS Right Care, it aims to support and care for systems to improve care quality, population health and system sustainability. So what NHS Right Care do, to give you some background, they diagnose an issue, or they identify, they develop solutions and guidance, and they deliver improvements for services. So the information on this slide, which I'll go through in a minute, can be found on NHS Right Care as a manual, as a toolkit to help you look or set up your high intensity use patient services within your department or hospital. So if we look here, it says the HIU service offers a robust way of supporting people who make high intensity use or impact of health services. In particular, A&E, non-elective admissions, primary care and mental health services. The HIU service aims to develop some of the most vulnerable people in our society to flourish, and a natural byproduct of doing the right thing for this client group has significant societal benefits, as well as financial savings to health and social care systems and the wider public sector. And it says there, drawing on support of partner organisations, including drug and alcohol services, housing, social services, police, and third sector groups as required, helps provide a personalised response to each individual circumstances. So Rhiannon, if you talk to her, she's very passionate about HIU patients, and she used to be a paramedic in Blackpool, and many years ago she decided that actually the best way to deal with her high intensity use patients is to have a coffee with them and sit down and find out what their issues are at the root cause. So she's a phenomenal lady, and I will say to you that even if you've got an HIU service, which many of you hospitals have, or if you're going to try and develop an HIU service, then Rhiannon she'll be right there to help you and to guide you to what you need to actually do to get funding and to get people on board to help you with services. She's an absolute fountain of knowledge. Next slide, please, Jeanette. So just carrying on from that slide, so we're looking with our HIU patients at demedicalising the issue, decriminalising the activity, and humanising the people involved. Good concept, brilliant concept, and I do appreciate for you hardworking staff in A&E, it's really difficult to do this when you're on a night shift and this patient's been in 3 times that day, which is why when they're not in crisis, the HIU team can really look in and delve into what matters to these patients and how we can support them. Next slide, please, Jeanette. So I've talked about NHS Right Care. Red Cross, British Red Cross, have been very involved with high intensity use patients. If we look at our neighbouring county, Worcestershire, their HIU service is run by the Red Cross. They do that in some areas of the UK, which is a good service. They've done a lot of research into HIU patients, and they've created this booklet called Nowhere Else to Turn. It's really interesting. It's got lots of stuff in there about health inequalities, data. But it's 2021. It was formed, and it looks at people who frequently attend A&E. They actually make up less than 1% of England's population. So not overly surprising, because we know that we see certain patients, and actually we've got our core group of patients that come in. So that figure to me isn't overly exaggerated or under exaggerated. I think that's probably right. The most common age groups across the country is 20 to 29 and people over the age of 70. Well, I would agree with that, 20 to 29. We've got a couple of older ones, mental health patients in particular. And of course, the people over the age of 70 are people who've got these really complex medical conditions, who are socially isolated, as with a lot of the rest of the population, especially post-COVID. But we do see a lot of younger people coming through, especially people that have, it says 20, but we've got a group of patients that are just teetering over from transition from paediatrics to adults. So we get those who kind of get lost in the system, and they suddenly come to our attention, and then we kind of hold them for a bit as they grow up, and we're trying to put the relevant support in place. And obviously this is changing. You know, if we look at age groups for HIU patients a while back, we found out that they were older, they were more male HIU patients, and also depending on where you are geographically in the UK will depend on what your patient group is like. I think the mainstay is that we have a lot of mental health patients. We share that, and we all see those patients coming through. We've got a group of learning disability patients that we see, and also for us we've got alcohol homeless patients that we see. So everywhere's different. I know that Bristol down the road see more homeless patients, so it's quite interesting to talk to other areas and just find out who their most frequent attenders or HIU patients are, or high impact patients are, all these terminologies that we use that I shouldn't use, so it's HIU. So again, the Red Cross look at putting in appropriate non-clinical specialist support, improving access to community-based support, and addressing these health inequalities. It's really important to say now that high intensity use patients aren't an A&E problem. I know people think historically they're an A&E problem, but I think it's been realised now that it's not fair that these services are put in place to deal with these patients, because actually they're all our problem. We all share the responsibility. We all share the risks with these patients. So I would say that it's evolving into a wider issue and more support in the community. So it's very positive. And of course, we all manage our HIU patients differently. So what we do in Gloucestershire isn't going to be the same as they do down the road in Bristol. But it's really important that we actually share good practice where we can and build on our services. Next slide, please. So just carrying on from the Nowhere Else to Turn booklet, the report, just some figures there. So 29% of ambulance arrivals are due to people who frequently attend A&E. 26% of all admissions, 16% of visits to A&E, and 2% of inpatient bed stays. Based on their ambulance, A&E attendances and inpatient stays, we estimate that this group costs the NHS £2.5 billion a year, which is absolutely phenomenal. I still, every time I read that out, when I'm doing teaching, I still can't get my head around the fact that we spend all this money on patients. And actually, by putting support in place and putting services in place, there is a cost saving, and it's a cost saving, but we're doing the right thing by the patient. So it's a win-win situation. I'm passionate, as you can tell. Next slide, please. So, as I said, HIU services in the UK at the moment, it's a very hot topic. The integrated care boards around you are very on board with high intensity use patients. The government wants us to deal with these high intensity use patients. And of course, it's a massive thing for A&E. So the delivery plan for recovering urgent and emergency care services, January 2023, it's in there. We all need to help deal with HIU patients, to free up time in the emergency departments, free up clinician times, waiting times, admission rates. You know, it's just so important, especially at the moment with the crisis that we are in with the NHS. You know, we're at breaking point. So if we can do anything to help with these patients, it's going to help the emergency department.
And of course, Rachel, there's the RChem report that was out about litigation claims in A&E, and how there's some really high value litigation claims against A&E departments, which were high intensity use patients, where things have been missed, and things have got worse, and consequently they've had a legitimate claim to quite a lot of money from the litigation pot in the trust concerned, which is not something anyone wants to be doing, is it? Spending on litigation when you could be spending on providing a service.
No, completely. And what the outcome of that report, the resolution report, was actually it's really important to, like you said, help identify and support these patients before they get to crisis point where they're coming into A&E. And actually in 2016, the RChem recommendation prior to that report was that if somebody had been in 4 more times in a year, then they needed consultant sign-off before they were discharged. Not always possible in A&E, but I know that especially with our patients, once they're identified, we do say senior review, and that's supposed to help with things like this litigation and risk management. But it's we know it's not always easy to hit those targets that RChem have given, but yeah, it's very important. And we'll always get, I'll talk about it a bit later, but we do get, obviously we get complaints from HIU patients. But I'll come to that in a bit later. You can say something, Jeanette, sorry.
No, I was just thinking that you said something and it just made me think of a question, and now it's gone. So that's just life, isn't it? And we'll move on to the next slide. And if a question occurs to me, I'll find an appropriate place to put it back.
I've just got to talk about the other bit on the other side.
Sorry.
Before we move on, but like you said, if you move on and you think of it, then just come back to me. So, and also we've spoken about social prescribers, which I will come to in a bit with our Gloucestershire model. So NHS England have put a paper out saying that supporting high frequent users through proactive personalised care delivery by social prescribing link workers, health and wellbeing coaches and care coordinators. So NHS England have really recognised the fact that we need to support these patients in the community to provide that support. So there's a paper out for that as well. That's in the references if you want to read that article, that report from NHS England. So I'm going to say now, effects of HIU patients on health and society. You've all probably listened to this, shouting things at me. There's many things and many ways that HIU patients affect our department and affect our staff. So, you know, we've got staff fatigue. That's a really important thing. In training, when I talk to ED staff, it's people get quite passionate about these patients because they're quite fatigued by them. Their compassion sometimes is quite low, and they just get very frustrated. Completely normal feelings. I'd love to say to them, you know, come and see these patients when they're not in crisis. You know, they're all lovely, and it's really difficult for them not to see that side of them, and just to sit down and have that conversation, what matters to them and what's going on in their life. I find it very humbling most of the time, talking about their history and what's brought them to where they are now. So I get that a lot in training, staff fatigue. And sometimes, you know, ED staff are amazing, and it's just keeping that resilience and being patient and treating every attendance like almost like they haven't met them before, and they're going to give them that compassion. Again, really hard when they keep coming in 4, 5, 6 times a day. But yeah, staff fatigue is absolutely massive, along with the fact that everyone's so pushed anyway at the moment with the pressures on our departments. That one there, violence and aggression. Our security team are supportive with these patients, but it can be really, really difficult to manage them. You know, safe holding team are brilliant. The police come when they're called, but again, can be really, especially the mental health patients, can be really, really difficult to manage when they're in crisis. So we see a very, very big amount of violence and aggression. And like with everywhere in the UK, we always say document datex, because we need a record of this. So and I think it's just with HIU patients evolving the way that we report and deal with these patients. They have a high mortality, much more likely to die even through misadventure. We're quite lucky in our county, as in we've got a lower mortality rates than other areas. Very lucky, but you know, percentage wise, 3 times more likely to die through misadventure than normal patients. So we're all aware of that. They all carry risks, because we know they do. We have MDT meetings about these patients. We all talk about what's going on in their lives. We all talk about their complex medical problems. We all talk about their high-risk behaviours, and it's just about trying to share that risk while supporting the patient. These risks are always going to be there, so it's just trying to manage and share those risks. So yeah, high mortality, it's a big one. Jeanette's already said increased complaints. I hear a lot from patients that I see that they've heard staff talking about them. They think that staff say kind of, you've been here once a day before, you shouldn't be here, and that kind of makes them feel like they're not worthy. We get all sorts of complaints, not just that from our HIU patients. We have relatives that complain because they're being validated or treated properly. And I would say we get more complaints from our mental health patients, because they come to A&E because it's their safe place, and they sometimes are made to feel that it's not a safe place for them. So then it sends them into even more crisis. But it might just be the way that they're feeling, that they're not being validated. So that is, I would say, from HIU coordinator perspective, that's what we hear the most of. And then to flip that around, we've gone back to the patients and we've said to them, well, how do you want to be treated? How, you know, what would make it better for you? So we've got a few patients that have agreed to help with our training, to help us kind of let staff know that's how they're feeling. And we might not realise it as healthcare workers, you know, it's our daily job. And I'm not saying that people do treat them differently, it's just how they're feeling. So it's just working with that patient to try and to work out how we can make them feel better and more supported when they're in the department. Not always easy, because sometimes you're going to not win, you're kind of losing all the time, but we try and do that, try and make that effort with them to try and support them. And of course there's as I said, the social stigma when they attend, not just from staff, I'm not saying staff, other patients in the waiting room. I had, you know, the other day I had one our most regular attender to the hospital say to another patient in the waiting room, "You're always here. Why are you always here all the time? You shouldn't be here all the time." And I was just sat there laughing, because this young lady who was saying it has been 72 times in 3 months. She's at the moment, she is right up there. She's probably worse than she's ever been, but she's having a ding dong in the waiting room because this person who is a frequent attender way down the list is sat in the waiting room. It's so they make each other feel like that. It's they've got a bit of a community going on at times in the waiting room. Our social prescriber can walk in there and there'll be 4 of them sat there having a chat, having a social, which is interesting. So impact on housing, other council services, including social care. This is another, talk about social care briefly now, because we'll touch on it later as well. A lot of our patients, our HIU patients that you see in the emergency department, have got needs. What those needs are sometimes aren't support needs or care needs. So sometimes it's just trying to get that appropriate support, and sometimes it does tip over the fact they do need social care support. So it's from a HIU perspective and a safeguarding perspective, it's putting that case forward and seeing if they meet that need and getting them that support. And sometimes it can be really difficult. So I would say that housing, oh my word, massive at the moment with the cost of living crisis. There's people that are in work that are being made homeless, and we've got our homeless patients, we've got, you know, our domestic abuse patients. There's not enough refuge spaces for them, so you see them in ED. You know, the list is absolutely endless with housing at the moment. And I do get a lot, everybody might agree or disagree with me in ED, or you nurses. We do get people coming in, they're not happy with their accommodation. They've fallen out with somebody at their accommodation. You know, they'd like to move accommodation because they'd like to move to a different area, which is out of county, which is going to be really, really hard to do. So we get a lot of problems with housing, and you know, our learning disability patients, we get one lady in, bless her, and if she has an argument with somebody, or if something happens at her supported living, she's in because she feels safe in ED. So yeah, it's just making sure that that we can help support with that in any way we can, but sometimes it's just not realistic to get somebody new housing. And the council obviously are absolutely stretched with all these housing applications, housing transfers. You know, it's endless. Impact on patient and family. I'll touch on this now, but we'll talk about it a little bit later as well. Obviously the patient's well-being. They don't always want to be in A&E. They don't want to be here all the time. They'll tell me they don't want to be here all the time, even though they are here all the time. And they'll say, they don't, you know, I've got better ways to spend my time being in ED. So it's the impact on them and on their lifestyle, and also on their family that are at home trying to support them. And we don't know who's at home. So that's really important as well. But I'll touch on that later, because I'm just going to talk a little bit about, I can't not talk about safeguarding later, because I am based in the safeguarding team. So we'll talk about that. We've talked about high risk behaviours. We all see it in ED with these patients. There's no getting away from it. You know, I quite often, you know, have a conversation with Jeanette about the fact that one day I will, I mean, touch wood, I've not been to coroner's court and I don't want to go to coroner's court, but there is a high percentage that I will be in coroner's court one day, because there is a patient that has died, and they might have a support plan that helps clinicians treat them, and this person's died, and they want to know if there's anything else we could have done as organisations to prevent this death. So again, that's highly probable. Cost implications for every service, we'll talk about that as well in a bit. We all know that this 2.5 billion figure that's been given to us in the earlier slide is absolutely real. And that is just, you know, if that's just hospitals, imagine the cost it has on wider organisations such as GPs as well. You know, it's probably eye-watering how much HIU patients cost the NHS and organisations. It's crazy. Strain on police and fire services. We've got the fire service often called because our patients are trying to get into the canal or the river. Police as well, because these patients are on bridges. The police have been picking up a massive workload from our mental health patients. I often feel sorry for them because they cover all sorts of things now. You know, even when ambulances don't get there quickly, they're kind of looking after these patients. So the strain that it puts on police, and of course we've seen, just to touch on the fact that the system for welfare checks and police support with mental health patients is changing. So that's the thing to look for in the future. So there's not going to be so much police support with these mental health patients. So it's just looking at other ways we can support them, and your areas will have mechanisms in place to do that. So I think like Bristol have mental health professionals out on the road, and it's just looking at ways that we're going to meet that need. Fire service, brilliant, especially with our patients that are high intensity use, alcohol patients who are sat at home hoarding, smoking, drinking. They are really good at going around doing their fire safe and well checks just to make sure these patients are safe. I had a HIU patient who not long ago who they couldn't physically get her out. They had to take her out through an upstairs window to get her out of the house because her house was so hoarded. So it's just relying on these organisations to help, even though they are, as we are, absolutely at capacity. Impact on voluntary organisations and charities. We rely heavily on charities, don't we, for support for our patients. Every geographical area is different, but we've got mental health services that are charity based. A lot of our housing support is charity based. A lot of external, we've got the Red Cross that help. You know, you've got Age UK. You've got all sorts of organisations that actually help support the NHS look after all of our patients. And we've got here in Gloucestershire, we've got a mental health cafe in Gloucester, and that is under huge pressure because they are trying to support these patients that are actually are quite entrenched mental health patients, and they're doing it without any they have got support from us and from mental health services, but they're doing it like on their own. So hats off to them, they do a really good job, but it's a massive impact on them. You've got people that are going way out of their way just to try and help these patients, to get them socialised and to give them any extra support that they might need. So that's there as well. Next slide, please, Jeanette. So part of this was to talk about Gloucestershire approach. There on the right is our infographic, which is, I got to say I didn't do this. I'm not great with IT, but my colleague did do it, and she's brilliant. So she's done this little logo for us. And I'll talk about services, but on the outside, we've got the community wellbeing service, primary care. We've got safeguarding, which is me. I am A&E trained. So I started in A&E and then I moved over to safeguarding quite a long time ago now, more than 10 years. So I've got that knowledge and I've got the safeguarding knowledge as well. So unique in the way that I work from the safeguarding team. We've got in our team, we've got an emergency medicine consultant who's amazing. We've got SWAST on the outside. We've got our very important data that we use. Pain consultant. How many of our HIU patients have got pain? A huge amount. So when we bring them in to see us as a team, most of them are really happy that they can get to see a pain consultant really quickly, because we've got a bit of a wait to see our pain team. And we've got the acute specialities there on the outside. And in the middle there, we've got Gloucestershire HIU team interaction and collaboration when not in crisis. And then in the middle, we've got the complex mental health, complex physical health needs, substance misuse, homelessness and housing, learning disability, domestic abuse, safeguarding, employment and financial issues. And there's more. So, you know, so I've already said that as a trust, we look after, it says 1,200 plus, but 1,400 people that come in 5 or more times a year. Now we looked at that. So back in 2020 through COVID, we had, we were really lucky to be part of a project. And the project was called the Shared Project, and it's called Supporting High Intensity Users Around the Emergency Department. So this was run by the Academic Health Science Network, and this was, and it was in conjunction with the BRI, because the BRI team have got a established HIU team. So we were given a day a week for my time. We were given a few hours of consultant time to help with these patients. And what they did is they gave us a systematic approach how we dealt with our HIU patients. And it was just that extra funding. And we've always had a HIU service for many, many, many years now. We're quite lucky, but we didn't have a funded service, and it wasn't overly structured because there was nobody doing it. It was part of, you know, it's part of your job. It's not your job. So it's kind of, we were doing things, we were working together, but there was as much structure. So we were given this money, and we did this project, and in that we had to use the reports that said patients that had been in 5 or more times a year. And we were really lucky to have really good results from the project, even though we were looking at some patients that weren't necessarily attending at the time. They'd attended a few months earlier, but we were able to demonstrate cost savings, which led to the fact that we were given funding for this team. So from the result of that project, we looked at our data and we thought, actually, we've been using different data before. We've been looking at patients attending 9 or more times in 3 months, and actually we think the data that we're using is probably more reactive and more proactive. So actually, as you can see there, we're now on 7 times or more in 3 months. So we've gone from 9 to 8 or more times in 3 months to 7 or more attendances in 3 months. So we've managed to, with the service we're providing, to help deal with more patients. Therefore, we can manage more patients, and there's less patients on that report. So we're really, really trying hard to. I don't think we'll get to 6. I'd love to get to 6 or more times in 3 months. People coming to ED, but I'm not near that yet. So if we look at people that have been 7 times or more in 3 months to ED, on our report we have about 65 patients a month maximum that have come more than 7 times. So from that report, we have maybe a third of them that maybe carry over to next month's report, and 2/3 of them we look at, and we can either help support them out, or they do, if I review them and they're coming in because they've got a significant issue at that time, they drop out of the report. So it's all about reviewing and seeing what we can do, even if it's just a phone call to another speciality or another support worker, just to see how we can help that patient. So we get that from our BI team. They're really clever, although I'm getting better with data now. I've been doing this job a few years, and spreadsheets, I'm getting there slowly. And what we also do, we cross-reference it with some data that we get from the ICB, so the Integrated Care Board. We're very lucky to have taken part in another project which involves social prescribing. So we now get money from the ICB. So we get money from the ICB not only to help the patients that we see in our hospitals and in our ED departments. They want us to help manage the wider health networks. So as they've identified, it's not just about patients coming to ED, it's about patients attending all healthcare settings. They really wanted to bring a team together to try and support these patients with social prescribers. So we got some money off them as well, which has been absolutely amazing. And we get this lovely, beautiful report, and it shows patients that are attending all sorts of health in the community. You'll see it on the next slide. There we go. There it is. It's a beautiful spreadsheet. What you'll notice first of all is the GP figures aren't on there. This is an error with the report. So going forward, they will be on there. Apparently they are there, but we just can't see them, which isn't very helpful. But also on that report, which isn't there at the moment, it's worth mentioning that we're going to add the SWAST, which is our Southwest Ambulance Service data, to that as well. So what we're trying to do as a team is look at these patients as a whole and not just manage the patients that are coming to us solely. So we do that as a team. We look at our hospital patients, and we've got our social prescribers who are funded to help with our hospital patients and these patients. We kind of combine the two. Now we've got the support. So you'll see there, to me, this data is absolutely amazing. So we can see there, if they live on their own. Obviously, I've taken a lot of the patient identifying data out. So we've just said if they're male or female. ED activity is really important. That's not just in Gloucestershire. That ED activity apparently is a combination of all EDs in the country. I have asked the data people at the ICB, actually, is there a way of breaking this down? Because it would be really good for us to see where else our patients are attending. We've got really good networks around where we are with the hospitals in the Southwest and bordering counties, but it'd be really good for us to know where else these patients are attending. I have contacted NHS England because historically there used to be a database. This was years ago, and it was very primitive. When I was in A&E, it was kind of, we used to have hospital hopper data, and every so often I'd walk down to the desk, the check-in desk, and I'd say, who's that patient? Oh, well, it's a patient that's been attending all the hospitals around here, so we know if he comes in, there's a picture of him that we know he's a hopper. And it was a very primitive way of doing it, but of course now we haven't got anything. So we have patients that are traveling around the UK, and the only way of dealing with that is if we know they're at a certain hospital, we can contact that hospital and just say to them, here's our support plan, there you go, we can help you, this patient, this is what this patient's had done, you know, this is how, it's just so much easier. So if I can get that data, that would be absolutely amazing, and it would save a lot of all our times trying to scratch around figuring out where these patients are coming from. There's minor injury activity there. We have patients, as you can see, the bottom one is a female who's 32. She's not bothering anybody apart from the minor injury unit where she's been 69 times. And that will be in 6 months. So this data is 6 months. We started with a year's data, but we're trying to get it more reactive. And actually, we're going to make it even more reactive and do it over a 3-month period next time when we do the data refresh, which is probably next month. So it's worth our time looking at why she's going there and how we can support her. And then we've got emergency admissions, elective admissions, 111 calls. Oh my, 111 take up a lot of the slack with calls. It's phenomenal. You can see there's a lady that's called 49 times in 6 months. And she's calling just to get that support and somebody to be at the end of the phone. So again, putting that support in place, whether it be befriending or anything, would help that situation. And of course, health anxiety. She may have health anxiety, so she is going to be calling 111 a lot. But actually, if we look that she's only been to ED 13 times, yes, that's a lot, but she'd have come a lot more. If it wasn't for 111, she'd have been in an ED a lot more. So it's trying to support from that perspective.
So 111 don't send every patient every time to ED, do they?
No, they don't. We think they do.
Quite clearly, they don't.
I don't know. Yes. So to be fair to them, when I got this data, I thought, do you know what? fair play. They do speak to a lot of our patients
a lot of
the time. So yeah, I've recognised that now. Mental health admissions, mental health community contacts, outpatients, outpatient follow-ups, community contacts. I can't read that because it's made it small, sorry. But that should say mental health. Oh no, I've got mental health community contacts there. Sorry about that. GP appointments, and then it ranks you from 1 to, I think we've got like 600 people on this report. So, and if I say to you that probably I can flick through and I probably know out of the top 50, probably 35, 40 patients, because most of them do overlap with our hospital patients, or they have done historically. So whether they're they were coming to ED, but now they're going to their GP all the time, or if they're ringing 111, we do tend to know a lot of these patients. And of course, with our high intensity use patients, we do get the ingrained patients that come in a lot, but we get patients that do peak and trough, and we call that reverting back to the mean, and that's not unusual, as we know, with this patient group. So again, it's just trying to catch them with this data when they're on their way up again, and trying to bring them back to the mean quicker. Yeah, it's really important. And we try to look at that data and compare it to other areas, but it's just really difficult because, of course, all our HRU patients are very, very unique, and they're very, very, very individual, and they've all got their own different needs. So comparably, we can't really compare them to other patient groups. So so we take this data, and this particular data is a data that we use to help work with our social prescribers. So this is the ICB data, but we also have hospital data, which we use. Again, I've taken a lot of columns out here. So we look at 7 times or more in 3 months. So we can see there that this patient at the top is 45 years old. When they last came in, I know this patient's a female. How many ED attendances in previous report? How many are in this report? And then if they're increasing or decreasing. And it just makes sure that we can like I said, be proactive with the way we treat our patients. And just on the right there, it says, do we have a patient support plan for this patient? So I know there, for example, patient 5, we haven't got one, but I know we're seeing them in clinic next week. So we will speak to that patient and try and look to put a support plan in place for them. And like I said, this data, we tend to overlap it with the previous ICB data, and we tend to work with our hospital patients as well at the same time with social prescribing, because it's really important to us that that we do give that holistic approach, not just to the ICB patients, but to our hospital patients. So, and it might be patients that we've worked with for a while, and we think that actually by putting some support in place, some more support, isn't going to be non-beneficial. But obviously with our mental health patients, we have to respect that there's quite often boundaries in place. So again, really have to triage this list and be careful who we put extra support for in place. So, and we get this monthly, as with the other one. And I print this off every month, and I go through every single patient and I see what's going on with them. I make sure that everything that can be done with them has been done, what is outstanding. And then at the same time, I look at contacting other teams such as mental health. I go down there for a meeting once a month, and I have a conversation with mental health liaison, one of the managers there, who helps support our team, and we'll look at them, every single mental health patient, in depth and see what can be done for them, who their support is in the community, and whether we need to have a MDT about them, whether we can just bring them into clinic ourselves and see them, or whether, yes, a social prescriber would be beneficial. So that's really important. Again, I've got to say, what I haven't mentioned before is functional neurological disorder, FND, NEAD, as we used to call it. You can probably all relate, we have a lot of patients with FND in the trust, a lot of our HRU patients, generally female for us, although, yeah, geographically it may be different. We don't see a lot of men with FND, we see a lot of females, and it's just looking at how we can support them, because obviously this their seizure activity gets worse with stress. So I'll quite often be sat down in neurology with the epilepsy specialist nurses, just saying, actually, could you review this patient for me? This is what's going on with them, and they can offer them extra. We've got a lovely nurse that gives them extra support. She's got a group of FND patients that she looks after. So it's just all about communicating and just seeing when they're in crisis. But yeah, obviously so many teams, so many MDT meetings about these patients. It's some patients we have like every 2 weeks, just try and work out what the next step is and how we can put extra support in place. Next one, please, Jeanette. Now, this is quite a good map. We were scratching our heads the other day because I'm not from Gloucester. I live over the border in Worcestershire slightly. So, and then I used to work in Cheltenham. So I'm not, I know Gloucester, but I don't know it in depth. So this is here, it shows we've got EPR flags for HRU patients, which is our electronic patient record. So what we do is when we've worked with a patient and we've put a support plan in place, this brilliant system can pick up where our patients are living, which is really good. So we've got here, right in the middle there's 2 dots. This is our county map on the left. And then the dot on the left is Gloucester City or Gloucester area. And the dot on the right is Cheltenham area. So we can see from that, the Gloucester area is quite, there's quite a lot of HRU patients in that area. And then it's broken down on the right to the Gloucester area itself. And we had a map out the other day trying to work out exactly where these are in the boundaries of Gloucester. So we can pinpoint it down to specific areas where we see where most of our HRU patients are actually living. And it's really, really interesting. And of course, as we move on with our IT, EPR is quite new to our trust. Well, I say quite new, it's been going probably a couple of years, but that's gone really quickly. And the more I find out about EPR, the more I find out about what it can actually do as a system. So I find this map absolutely amazing to see where our patients are living. Next slide, please, Jeanette. So we've spoken about electronic patient record. We've spoken about the use of our data reports in the trust and community to identify our patients. It says there we don't just use our BI reports. It says down the page of it there that we take referrals from ED, we take referrals from inpatient wards, acute wards, we take referrals from the PALS team, because they can be working with patients that they're finding really difficult, who are complained about their management or about their care. We can often bring them in and sit down and put a support plan in place for them, and it just makes them feel that they're being listened to, and they agree a plan for when they come in, so we know how they'd like to be treated, if this is possible, because sometimes we have to bring them in and say, we understand this is what you want. Actually, this is not always going to be what you get when you come in, because what you want isn't realistic. So it's just having that time with them to work this through face to face. And of course, we've got our consultants there too, so we can do that in a really good way. We have structured clinics, we have face-to-face clinics, so we have one a month for the trust, which is 4 patients where we see them for an hour each. They can come in on their own, or they can come in with a support worker or a social prescriber, and we can really sit down and get down to the nuts and bolts of actually what's troubling them, medically what needs to be done. Do we need to chase up referrals? Is there any outstanding investigations that need to be reviewed? Is there any other investigations that we think is needed, or just an overall MOT of their health, and putting everything down on a plan just to make sure all staff are aware and how they should be treated when they come to ED. And it's also really important that the patient knows that's how they're going to be treated, so they have realistic expectations when they come in. And they're not just going to get the CT scan every time they rock up to ED. So it's making sure that everything's there and very boundaried at times. I've said about mental health support in clinics. We have a bi-monthly mental health clinic where we just see our mental health patients, and we have that mental health professional there to support us in clinic and support the patients. We have another clinic, which is a social prescribing clinic, and that's done via, it's online, they don't come and see us, but we see 8 patients a month for that, and they have half-an-hour slots. It's like a marathon, actually. I don't know how GPs do their 15-minute slots, because even after seeing speaking to 8 patients one after the other, it's quite draining, especially when they've all got a big backstory, they've all got complex history, they've all got, there's no one thing that they want, there's layers of things that they need support with, so it can be quite challenging, but it's our chance for them, with them, just to say, do you know what, here's a person that can help you. We can't help you buy electric, we can't help fix your boiler, but we know somebody that can, and that person's here with us today. So they're going to ring you tomorrow, and they're going to have a chat with you and come and see you, and they're going to try and support you. We have a monthly MDT meeting to discuss patients with mental health, which I've already spoken about. Alcohol HIU leads, really important, and the alcohol liaison team within the hospital. So through COVID, it was really difficult for us because a lot of our HIU alcohol patients, sadly, we had a higher mortality rate with them than usual through COVID. Very, very sad. They were isolated. You know, quite often the people that would buy them alcohol weren't able to get there or didn't want to go out because they couldn't go out. And we had a lot of we had a few patients that died then. And then at the moment we're seeing a rise in more alcohol patients coming through, HIU patients. Very incredibly hard to deal with because they're high risk behaviours. They come in, they present as having they come in as looking, you know, appearing vulnerable because they're self-neglecting at home. You know, their properties are in a terrible state. So working with the alcohol teams for us is they're so helpful. It's so important. I said about a pain consultant, safeguarding. That's me in the team, and Jeanette's my manager. So Jeanette's always there on hand if we need support at management level, and it's just or need that advice. And it's really, really interesting because I am based in safeguarding, but what I can tell you is that I say a name of a patient in the office, or my colleague will say a name, and about 3 or 4 of us know the patient. We all share the same patient. So I sit with the LD nurse, I sit with the substance misuse specialist, I sit with the homeless specialist nurse, domestic abuse lead for the trust, Dole's mental capacity lead for the trust, and we generally all know the same patients. And a lot of my HIU patients that I know have got an element of or have had domestic abuse in the past, and actually that's really beneficial, because if I have somebody that's coming in a few times, I can quite often think, actually I know them from the DA work stream, and you can quite often pinpoint the fact that there's a relationship at home that they're not happy in, which is why they're coming to ED as a safe space. Our ED consultant's brilliant. She does a lot of mental health patients. There's a really good overlap there. We've got a complex emotional needs community service as well, which helps us with our HIU patients. The acute medics, the surgeons, you know, all sorts, and of course the ambulance service, which we've spoken about before. We have monthly meetings with the ambulance service, just to try and share our plans. What the South West do as an ambulance service is they can't manage all their HIU patients. What they do is they manage the top 10% in the whole of the South West, and there's like 2 or 3 of them doing it. They do an amazing job. So it's really important that we pick up that work from them and help support them, because they're trying to kind of have that battle on their own, and it's a really hard battle to have. So it's really important that we support them. And also, you know, we have had paramedics ring us from somebody's house because they're not sure how to manage this patient who's refusing to come to hospital, but's taken a huge overdose and is screaming, so and in pain. So it's you know, it's really important that we work closely with SWAS. As I said, all plans are available online now on our electronic patient record. Everywhere's different in the country. Everywhere's got different IT packages. Some may hate it, some may love theirs. We've got this EPR system. So we've got this little icon here that says high intensity use. This only comes up on the ED tracking board, and it just means that there is a patient support plan in place, which can be found on the external documents tab, which is what it said there. So the clinician can go straight to that external documents tab. They can see exactly what's going on with that patient. That will disappear once they've left ED and gone to the ward. So we have this little tick at the bottom. Document, it looks like a document and a tick, doesn't it? And that goes through to the ward screen, and it just says that there is a clinical plan in place for that patient. Again, really important. It's really important these are really obvious to staff because of the risks that some of our patients carry. So EPR has been quite revolutionary for us because we're able to put them on the system. Before that, we had they were on a shared drive, and before that they were in paper files, which doesn't seem that long ago. We've come a long way in such a short space of time. So yeah, I'm feeling old now. So this slide is just an example of our patient support plan. We used to call them management plans. Sounds a bit harsh, managing somebody, doesn't it? So it's, you know, we call them support plan. It's kind of, it's a lot softer than managing a patient. So you can see here on ours, RChem have got an example on their website. If you Google HIU RChem, they have got an example of what you should have on here, and it's kind of, it's what we've got. You can kind of play and add what's good for your area, but we've obviously got their physical, mental and social. So we give a bit of background information about all areas of a patient's life. Actions in the community, really important if you've got somebody who's quite impacting on the community, especially district nurses. We can work and put plans in place with them. We've got their SWAST, stroke ambulance crews. Again, really hard to deal with a patient who's got health anxiety but cardiac problems. So it's just making sure that they know when it is safe to leave the patient home or when they need to convey them. And with the information that we can provide, it helps them with their decision making. And again, with SWAS, you know, it's important that if we think a patient shouldn't be coming in a lot, then, and there's reasons why, they can put categories on patients, like, so it means that they will, it might be that if they call 999, it's left and then they're called back half an hour later. It could be that if it's a certain problem, that an ambulance isn't dispatched straight away unless it's a Cat 1 or 2. So there's all different things that SWAS can do. So again, important. What the patient would like. Again, what actions to take in the emergency department, and actions to take place if they are if admitted to hospital. And hospitals, ward staff find this really, really helpful. So again, we can cut and paste that or take bits out, because you might have an HIU patient that never calls the ambulance. You might have an HIU patient that never gets admitted. A lot of our patients don't always get admitted. We've got patients that, like as you will, that come to ED all the time but never get get past the door to be admitted, which is good. So that's not always applicable. So it's just using that to and obviously name of who's doing it, actions and who's involved, who should we ring for extra advice, what social work are they open to, who's their community mental health worker, who's their Nelson Trust worker in the community to help them because they're a vulnerable woman, you know, all sorts of things. Are they known to the sexual assault unit? It's, you know, if they are, all that can go in there if they've got support workers there. So and the version number, some patients are on high versions, and then it says there date issued and date reviewed. So all the information that you need can go on there, and that sits on in their clinical online records and not in their notes, because if it goes in their notes, you don't know if it's a new one or an old one. So we tend to say, don't print them off because you don't know what version it is. So we've spoken about our HRU social prescribing team. It's been revolutionary having them in our team. We've got 2 of them, which doesn't sound a lot, but 2's better than the 0 that we had before. And we just work so closely with them, always on hand, because obviously these are high risk. So they might have a patient that rings them and says to them, oh, I want to kill myself today. And they're like, oh, hang on, I'm a social prescriber. I'm going to ring one of the clinicians at the hospital to have a chat with them, who can then talk to their mental health worker or support in that way. Or it might be somebody who they've got concerns for safeguarding at home. So they can always ring up, they can always talk to somebody. It's really important that they're supported. So at the moment, we've just got a worker for Cheltenham and Gloucester. We've got 6 localities in our county, so we would like 4 extra for the other localities, but at the moment we've only got funding for the 2 main areas, Cheltenham and Gloucester. So we've got 2 lovely social prescribers that work with us. Next one, please, Jeanette. So typical issues that are addressed in clinic and then passed on to when they come out of clinic, because they can take a long time. So housing, I've said about that. Finance, cost of living. So sometimes you speak to patients and they can't afford to eat. So actually the food voucher that they can get from the worker, the money that they can get off their electricity bill, they can get like £500 grants towards their gas and electric. That all that extra money that they need that they can help support with is just so beneficial now in this day and age. They can help with buying mobility scooters. Our social prescribers bought our most highest attender, well, not bought, but applied for a grant to get her a bike because she wants to go for a bike ride. So she's asked for a bike for her, which she's going to get. So she's just waiting for that at the moment. I've said about carpets, white goods, curtains, everything. They can help with everything. So really helpful for our patients. Food deprivation, they've got pantries at their wellbeing centres. We've talked about fuel bills. Household items we've also talked about. This is really important with some patients. Had a young girl who she was very, very young with a baby, and her partner had her abusive partner had taken everything out of the house apart from the stuff for the child. And our social prescriber walked in, and all she had in there was stuff for the child and a fridge freezer and a cooker, and which belonged to the perpetrator. So he had that completely over her. So we were able to buy her those white goods, and then he didn't have that control over her. And also, yeah, curtains and everything. The house was furnished with support of the social prescribers, which is really heartwarming. Attending hospital appointments in our face-to-face clinics. Generally, we have a social prescriber bring 1 or 2 of the patients into us, because actually they need to bring them in, because if you're relying on that patient coming on their own, they're not going to come. So really important. Employment alternatives, they can get them volunteering. They can look at getting them, help them with applying for jobs, filling in all the sorts of paperwork for that. They can give them life skills sessions. They can help with that. All sorts of things. So it's just helping to get that person back into employment. And normally it starts with a little element of volunteering, and it's built up from there.
Is that the category that going down to the man shed or natter falls under?
But well, that's the social support network. So
I beg your pardon.
That would be walking groups, baking groups, gym membership they can pay for, man shed. Yes, man shed is a place where they can go and build things and do carpentry, and our social prescribers will go and pick the patient up and take them there. So because you know with a lot of HIU patients, if you just try and signpost them, it's not going to work. So they take them and they go with them. And we have befriending services they can talk to rather than ring 111 or come to ED or go to their GP. And also we have a patient that became a befriender. She was a 72-year-old with a massive backstory of sexual abuse and really, really struggling, post-traumatic stress. Never had counselling for that. So we're able to put some counselling in place, and eventually she's become a befriender herself. So even though she was an HIU patient, she's now helping other patients, which is nice. So yeah, it's addressing that disconnection from society, which we've all seen through COVID is increased massively. Has had the opposite effect for some people. I saw I was at a tap-in for HIU patients last week, and there was a mental health patient there who was a lived experience patient who was giving us a talk, and she said actually when COVID hit, she felt this was a turning point for her because everybody was isolated, not just her. So that was her turning point. But we don't often hear those stories. We hear the opposite of social isolation through COVID, and a massive increase in health anxiety. Yeah, really, health anxiety is probably one of our biggest things and the most challenging to deal with. So it's just getting these people to do other things rather than speaking and thinking about their health continuously. And mobile phone and internet access. Oh my word, how many patients don't have internet? We all take it for granted nowadays. Yeah, I'm sat here talking to you now, but a lot of our patients haven't got that access. So again, it's our social prescribers going in, and maybe if we can't see them in clinic, they can go and do a video call there. And if they haven't got internet, they can't fill in any benefit forms. So quite often they'll go and do all the benefits forms with them, PIP forms for enhanced support, financial support. They're really hard to do. You've got to use the right terminology. You've got to fill them in the right way. They say normally the first one's rejected. So these social prescribers are really good at filling in these forms. So massive help to us. Next one, please. Oh yeah, that word, digital exclusion, that's very big from the previous slide. I wrote an assignment on that. That was quite interesting. The amount of people that are digitally excluded in society nowadays. Everything's online. Every form's online. So what do our social prescribers do for our cohort? They're not, I say they're different from the normal. I use the word normal. That sounds a bit, derogatory sometimes. But when we say normal, we think about the social prescribers that just signpost people. Again, that's brilliant, but wouldn't work for our patients because they need that support. It's worth mentioning now that when we talk about social prescribing all across the country, you might have this support in your hospital, you might not have this support. We're just about to employ a social prescriber for our trust, so that'll be interesting. But when we talk about social prescribing, everywhere is different in the country. Everyone's got their own definition of what social prescribing is in their area. There's no formality to how these social prescribers work. So I always find it so crazy because I get money from the government for social prescribing, but there's one area can do it very different to another area. So I don't know how your area works. It could be better, worse, equal to what we do in our county. So and also our HIU social prescribers do work closely with the GP social prescribers because the social prescribers are seeing patients in the GP practice as well. So it's really important they work together. We've talked about the greater intensity and demand. Our poor social prescribers, some patients ring them once, twice a day, but it's once, twice a day that they're not coming to A&E or going to ring 111 or going to minor injury or going to their GP. So it's just trying to be there when they've got that anxiety at the end of the phone, but also trying to manage that, because we don't want them being inundated with calls. So we go nicey first of all, then we can put boundaries in place for these patients, which is also really important. So it says there relationships take a lot longer to develop. We've got some patients that don't trust them. We've got some patients that won't engage, and then they eventually engage and wonder why they didn't in the first place. We've got some patients that that it's taken like 6 months to kind of engage. We use the word non-engagement, which is we need to flip that to how can we engage with this person, and we just keep trying. We write them letters, we leave it a bit, then invite them back to clinic, and we just take the softly approach and just see if we can engage with this patient. We're not going to win them all, but we do try and give it the best opportunities as possible. And I said there that signposting is ineffective on its own, and that these poor social prescribers do hold, at times for short periods, hold this risk. So it's important that the team are around to support them, which we all are. They quite often ring the safeguarding hub if they've got concerns, and even if I'm not there, somebody will help them, or one of the consultants will be on hand. So they've got that support. Next slide, please. So we've spoken about support and some of the good outcomes. What I wanted to do is talk about the cold, hard facts of cash and figures, because actually we all know that apparently NHS England give us this money via the ICB and for HIU patients. It's not ring fenced in any way, so it comes down as a block payment to the ICB, and how they use it for HIU patients is it's kind of a bit how they want to invest in services. So it's not ring fenced. So what we want to show is that actually we can do the right thing, and we can save money, and we can save time. So what we looked at is 12-month data prior and post HIU team intervention, and we've looked at 71 patients. So what we do is we look over 12 months, because we've got that peaking and troughing and returning to the mean. So some of these 71 patients, we would have put an intervention and they stopped coming, others would be attending. So it's looking at that average monthly data, just so we can get kind of a bit more of a fair data capture. So if we look here, average monthly reduction in ED attendances after intervention is 97 ED attendances a month. So out of all those patients, we've got 97 people coming in less times. In reality, it's probably half those patients that are still coming in and not attending. We've had a reduction in admissions to acute beds. That's 21 less admissions. Average monthly cost savings to ED, that's £14,515 a month in ED. These figures are really hard to get. I mean, the BI team linking with the finance team, because we all know that ED attendances are all costed differently depending on what level of treatment they've had. So I take guidance from the BI team that give me these figures. And average monthly saving on admissions is 22,458. The monthly hours saved in ED was 632 hours. And we've saved an average bed days of 38 days a month. So I've put there, these savings are a byproduct of aiming to provide the best support for HIU patients, and not just a focus of the work. So it's just, as I said before, we can save money, but it is just doing the right thing. So next one, Jeanette, please. Any questions so far? And then we'll move on to
I think we need a quick break, don't we?
Sorry, I'm talking and it's just I get all carried away with my patients. So
Let's have a quick break. Whoops, I've gone 2 slides instead of 1. Let's have a quick break. Okay, having had a break and a stretch and a think, because Rachel's given us quite a lot to think about, let's plunge back in for a bit more. Yes, the passion's showing. That's good.
I'll try and bottle that for Monday morning.
Okay.
Okay, so before the break, we spoke about our service. So it's really important that we combine a trauma-informed care approach with the personalised care health model. As you can see there, King's Fund, massive, tackling poor health outcomes and the role of being trauma-informed. Like I said, it's thinking about the issues behind why people are coming in, which is really important. And that initiative on the left there is it's our Orange Folder One Gloucestershire initiative, and it is it's all to do with personalised care, and it's quite a big thing in our county, and it's what matters to me. And this is a folder that we give our patients to put their support plans in, and it's the folders that the ambulance crew can look out for, and any other information from any other community providers can go in there. So it says there, individual trauma results from an event, series of events, or a set of circumstances that is explained by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. It's a good quote there. It's a good definition. So I won't speak about trauma-informed care for too long, because we all work in ED, we're all healthcare professionals, and we all recognise what trauma can do to somebody. People have varying degrees of trauma. Some people you speak to and you think, crikey, these people have been through so much, how are they still functioning? Other people can describe trauma as, you know, as parents getting divorced, that's a huge trauma for them, a break in a relationship. So trauma to everyone is different. So it says there, what is trauma? Physical, sexual, and emotional abuse. Childhood neglect, that features quite strongly. Poverty and discrimination, separation from a loved one, family members with mental health or addiction disorders. And we've got a few patients that have grown up in drug households and had an element of neglect, and they have attachment issues. So it's very sad. And it says there, what is the impact of trauma on health? We see this every day: heart, lung and liver disease, depression and anxiety, sexually transmitted diseases, autoimmune disease, substance use disorder, and higher instance of high risk behaviours. We're all used to these behaviours, so we do. This is our A&E bread and butter that we're looking at there. And in the middle there it says trauma informed care. How can we be trauma informed? We can switch to what is wrong with this person, to what's happened to this person. So asking them a bit more about their history to try and realise why they are in the way, why they're in the situation they're in today. Recognise links between traumatic experiences, unhealthy behaviour and health outcomes. And it says there, do not underestimate the power of the clinician who smiled and didn't judge me. And that's exactly what that lived experience person said to me last week when I asked the question, what made the difference? And she said, sometimes it's just when somebody smiled at me. Be proactive. How can we support this patient in hospital? We can refer them to the HIU team. That's what they can do. So it's just making that referral. And yeah, just switching to how can we support this person. Next slide, please, Jeanette. I've got to speak about safeguarding in HIU patients. It's so big. So, you know, it's very important. HIU patients that have experienced life trauma are more likely to have safeguarding issues. We've spoken about domestic abuse, very high in our patient group. Substance misuse, again, you've got your alcoholic patients, you've got your drug abuse patients. We've got a lot of IV drug users that keep that pop into our report that need supporting. So it's important that we try and support them and get them out the my reports quickly, which isn't always easy, but we've got an amazing team. Said emotional abuse, self-neglect. Again, self-neglect and safeguarding isn't always a safeguarding referral to the safeguarding unit, but it is what support can we give this patient. And actually, sometimes it's very complex and very hard, but when they come into hospital, we quite often have that opportunity to try and sort that safe discharge. Financial abuse. Oh, so many of our vulnerable patients who are quite often picked up outside A&E and might have a learning difficulty, just vulnerable. They can be financially abused, as well as our IV drug users. So really important to flag that. Sexual abuse, homelessness we've spoken about, physical abuse, modern slavery, vulnerability factors which lead to forming unhealthy relationships. We see a lot of this, and we just trying to manage somebody who keeps going back to somebody who's has a negative effect on them is really hard, or they go from one relationship to the other. So it's just trying to, again, support those patients. Organisational institutional abuse. Again, we see this. And at the bottom, I've got consider capacity and are there any unmet care needs. The C word in safeguarding is capacity. Again, I keep saying about alcohol patients, sometimes we think they have got capacity, but actually they haven't. When you look at their CT scans, they've got alcohol-related brain damage. Yes, they've got capacity there and then, but have they got capacity to go home and look after themselves, to manage a tenancy, to pay their bills? They haven't. Have they got capacity to protect themselves from people cuckooing them? They haven't. So really important. Capacity in mental health patients is complex, and the mental health team a good support to us in our emergency department, and also physicians that know these mental health patients well, to enable them to do a capacity assessment. It's just that constant reviewing capacity, so that's important. And also, are there any unmet care needs, any care and support needs? If there are, we can involve adult social care and get them that support. So much easier when a patient has a social worker. Worth their weight in gold with these patients. So again, it's worth investigating. Can't always do it in A&E. So again, if you've got an HIU service to refer to, that's brilliant. Or any other services you can refer on to help investigate this. Next one, please, Jeanette. Really quickly as well, who's at home? Again, important. Children. You might have a patient that's been in a fair bit and not realise there's a child at home. There might be a child at home. We have patients that we've had to do children's social care referrals for because they are using their children to seek medical attention. They're going through their children to get try and get treatment for their children they don't actually need. They've got they're emotionally harmed because they're in the environment where the parent is always seeking medical attention, and it's not healthy for them. So we have got some of our HRU patients that are on child protection plans because of referrals that have been made about this. And also patients that we've picked up that in a domestic abuse household and we've referred on, and they are recognised to be at risk from people that shouldn't be in the house. So it's always worth making the referral to either children's social care or via your HIU team to make the referral on your behalf. We've got more time to investigate and talk to organisations, so if you have got a team, refer on. Another elderly relative, is your HIU patient a main carer for a vulnerable person, or are they not coping as a carer? So we've got patients that they live with their grandparents because their parents can't cope with them, and it's having a negative effect on these poor elderly grandparents. Or if they're caring for somebody else, that's a red flag because they can't care for themselves. So always worth looking out for. I've said about a perpetrator of abuse. Do we need to try and engage with the victim of abuse to leave a relationship? They might be the perpetrator of abuse, so it's important that we look at all angles. And a colleague in my team will love me for saying this, it's pets. Do you know what? This week has been a pet week. So it's worth thinking, if you've got an HIU patient or any patient that's in hospital, is there a pet at home? Because the police do not like breaking down the door to get that pet out. That is a last resort.
RSPCA.
RSPCA. If you can get in the house, Jeanette, the RSPCA.
Indeed.
We've had all sorts of animals. I had a patient last week that wanted me to go and feed her cats, and I was like, I'm not going to do that, but I will get the RSPCA to take them. And then all of a sudden, she had somebody else to look after them. So we'll leave it there. That's out of my job description, I think.
Definitely, you're not going to anyone's home to feed their cat that's a patient. I draw the line.
That's come from my manager. Next slide, please. We've spoken about personalised care. My colleagues will love me for this picture. This is a picture outside the hospital for a personalised care campaign that we're part of. And so it's a collaborative partnership working with One Gloucestershire partners to co-develop a universal approach for personalised care that benefits the people of Gloucestershire. So that's our orange folders. And what you need to ask the patient is, what matters to me? What matters to you? How can we help? What is really troubling you? And I love that little box that says ask, listen, do. So simple but so effective. Personalised care also, you can get personal health budgets through personalised care. If you haven't got an HIU team, or you need extra funding for your HIU team, there is a personalised care budget that the ICB have got. So there's always that funding nationally for you to tap into if you haven't done so. If there's a project you want to do a personalised care, it's always worth contacting your personalised care lead at the ICB. We're told there's money there, so we need to start accessing the money to improve our services. Next one, please. We talked about the King's Fund with health inequalities. That's quite stark. 80% of our trust HIU patients live in areas of higher inequalities. So it's the lowest decile in society, percentage-wise. And it says there, avoidable, unfair, systematic differences in health between groups of people. And we've got to think about how we can help with this. So they have trouble accessing healthcare. They have problems with income, housing, environment, transport, education, work and diet. We see more behavioural risk factors such as smoking, inactivity, obesity, alcohol consumption and high-risk behaviours. And this has been further impacted there, as it says, by high mortality rates since COVID-19 and the current cost of living crisis that we've got. The ICB data we got will establish where our patients are living in the county, and as we've seen from the previous map we've already shown, we can quite clearly see where these areas are, and it will give the ICB more information about where they need to invest in areas to try and improve health in those areas. So it says there, the life expectancy for a woman in the least deprived 10% is 86.4. The most deprived 10%, so in the areas of high inequality, it's 78.7. That's an 8-year age gap. So you'll live, if you live in a better area, you will live 8 years longer. Quite astounding. Men in the least deprived areas 83.5, and the most deprived areas 74.1, and that's information from the King's Fund in 2022, and that's a 9.4-year age gap. You can ask yourself what came first, the chicken or the egg, because I was thinking about this, and you can kind of think, were they born in that environment, or are they now in that environment because they are an HIU patient and they can't work? they've got medical issues. So it's looking at, you know, what came first, but we do see that most of our patients live in these areas. And of course, increased investment required in these areas to help reduce the inequalities gap. And like I said, they're just looking where they can invest. So again, health inequalities. I was at a talk with NHS England probably about a month ago. I was sat in this very room, actually. I wasn't working, but I logged on because I really wanted to find out about funding. And I knew that Rianne was going to be on the call. So there is a lot of money to work with health inequalities. And there is money, NHS England have said there is money in the health inequalities budget to work with these high intensity use patients. So again, it's just finding out who your health inequality lead is at your local ICB and accessing that money and trying to get some money for your HIU team. Even if you put forward a project or a new position to try and look at these areas of inequalities and working with these patients to try and reduce the health gap, then there's money there. So again, it's just looking for these pockets of funding to help your hospitals. Next one, please, Jeanette. So this slide here is just a slide that I thought I'd put in, feedback from patients. This is one of our patients here who's doing a art class, and there's just a quote that we've got from her above there. Saji has been a wonderful social prescriber. She has done lots of things for me, including food vouchers, energy bills, furniture, and college courses. She is nice, encouraging, and makes me smile. This lady came into clinic a few weeks ago, and she just said, "Please don't take her away from me." And we said,
"How lovely! How lovely!" That's really nice.
She's lovely. She's and I said, "Oh, you know, we're not going to, not, you know, because actually with these patients, the social prescribers can ordinarily they can't, but with this patient group, they can stay engaged for a longer period of time with them. Some of them they'll never take off their caseload, probably like this lady here, because she loved the social prescriber. And we've seen a dramatic change in her hospital attendances. And she now recognises why she was coming to hospital, and says, "No, thank you very much. I've got better things to be doing now. And I've got Saji to help me." So happy days, I'm happy. And there she is there doing an art course. So that's one of our lovely stories.
So how often does that lady come in now, Rachel? How often was she coming in before she acquired Saji? And
so
how often does she come in now?
So she was, at one time, she was in about 15 times in 3 months. And then she was floating around about the 9 times and then peaking back up again. And now she's not in at all. She doesn't come in.
She's got better things to do with her day than be up the hospital.
She
excellent.
Has. And it's excellent. And it's so heartwarming. Obviously, she's got things that we're still supporting her with. So her pain levels are bad. We're supporting her with her smoking and things. So there's always, the work's ongoing. But yeah, definitely a lovely lady, lovely success story for us. And then on the right, I suffer with severe anxiety as I have information from a friend that I'm entitled to benefits, which I have never called, as I was very anxious to call for the last 2 years. This is their words though. Saji was well versed and informative about the areas and questions that were very vexing me and causing me most apprehension recently. I definitely shall be attending more community groups with the support of Saji as planned. I feel more focused. A journey of only a few meetings has really changed my life and has given me confidence. Thank you to HIU team and Saji. That's their words. So that's this man was this is only a bit of his letter. He wrote about 3 pages actually.
Oh, how lovely.
Yeah, absolutely really, he's also stopped coming as well. So
that's brilliant.
She's doing wonders with him. And actually, for him to take the time to sit down and give us his feedback was, yeah, really informative and very heartwarming. So that's just a couple. We have wins like this, which counteract the many times we don't win, or we're kind of battling against walking through the treacle. It's nice to have these positive patient stories. We're not going to win them all, but we can try and start winning them all. That's what I say. So yeah.
That's very lovely, isn't it?
Yes.
It's nice when you get some feedback from a patient and you kind of get some insight into what's gone on. And what you can see in both of these is the person who's written this has got insight into what their previous behavior was.
Yes.
And they perhaps at the time they were doing that didn't get why they were behaving like that and what they were trying to achieve and clearly not achieving. But it's nice that they've kind of, and what's really interesting actually is the stuff they've pinpointed has nothing to do with health.
Oh no, wouldn't it be simple? Like if we had our HIU patients that had pure health problems, that's what we're comfortable with. Yeah, we're comfortable with that. But it never is. I think at the top 60, we've probably got about 2 with health problems. The rest of them have got layers and layers and layers of other problems that we have to help manage. And interestingly enough, I had, when you say about the feedback, I had another patient in clinic last week, and he said, do you know what? I've realised that I'm not ugly. He had no self-confidence, and then he said to me, and then he turned around and he said, and do you know what? He said, I don't need to come to A&E anymore because I've realised that I am worth something. So sad.
Oh, that's sad.
And that's another one of Saj's patients as well. So they're both, we've got 2, and we've got a male and a female. They're both phenomenal. They both do amazing work. So we definitely don't want to lose them. And actually, we've got recurrent funding now, haven't we? So we're not going to lose those 2 social prescribers that we've got. And it's such a big thing now in the UK. You know, these RHIU teams have got to move forward. We've got to grow. We've got to help manage these patients. So if you haven't got your services in the hospitals, you need to put a case forward, get a business case together. I spoke about the Academic Health Science Network previously. As a result of the project we did through COVID, they are going to be trying to roll it out across the UK and other areas. They've contacted us last week for some ongoing data which they're putting into a central port. So there might be an opportunity if you haven't got a team that the Academic Health Science Network in your area might be taking on a project like that as well. So we'll help you co-develop a team. So yeah, it's trying to find where the money is. That's the name of the game, to provide the services that we need.
From the perspective of somebody doing our leadership program here, who's likely to be a band 6 or maybe not, or maybe just starting on a band 7 post in A&E, you know, understanding where that money comes is like, that's out there, isn't it? It's well, I get paid my wages. I don't really worry about how come there's money there to pay my wages. I understand about taxes, but you don't really think wider than that about how you get money to somewhere. And I think
it's would really want hard.
To say it is hard. It's a lot really harder than people make it sound.
Yes.
And even when people are saying it's really hard, it's even more hard than we're making it sound. But we would say this, wouldn't we? There's a lot to be said for the HIU team not sitting in A&E on the A&E staff roster.
Yes.
And being outside A&E so that you have more reach across the whole trust. So please don't feel that your HIU patients should be your responsibility and yours alone. You did say that earlier, Rachel, the benefit of A&E just cannot get to the A&E cannot fix this.
No, you're busy enough.
They can wave a flag and go, hello, this is a problem. Because I know we've noticed, haven't we, that the A&E department seem to contact us when someone's not quite reaching our threshold. There's a new patient here, I think might need a plan.
And that's a really important point, actually, because by working with the patients lower down on the list that are just starting to come to our attention, we can have much better outcomes because they're not so ingrained. So it's turning those patients around a lot quicker. So that's a very good point. And like I said, we can now do that, whereas before we couldn't. So
yeah, and just think all that misery that we're able to avert because people don't get to that entrenched position where they don't have other coping strategies and they're not easily guided into other coping strategies by a social prescriber or whatever.
Yes. And also I'd like to say that we have had management buy-in has been good for this as well for our trust. So get your managers on side, get your stakeholders on side.
Yeah, it is slightly interesting who's been our biggest champions, because our biggest champions actually with this work have been the deputy coup, which is not where you'd expect to find the support necessarily, but has been amazing.
Yes, we've been lucky. We've come actually quite far in a short space of time, and hopefully we'll carry on like that. But it's been a mammoth job just to create the service that we want. I mean, the IT alone has been, actually probably the IT has been the worst part. That and the funding, the IT is close. Just setting up all our IT systems and yeah.
But now you have lovely data reports and you know exactly what you're looking at.
We do. I think that was the last slide, wasn't it, Jeanette?
I think it might have been. No, some references, which we will pause on so that anyone who's, as you're viewing this, you've got the opportunity to take a photo if that's important to you, or just you want to pause and note down any particular references. I will say that Rachel's tip of Google HIU RChem, I tried it after she said it, works a treat. Works a treat. All sorts of lovely references come up that you can get straight away. Okay, so for tonight's lecture, there's the evaluation QR code. So you will need to zap the QR code and that will take you to an evaluation form. Just scroll down till you get to the right lecture. This lecture's on high intensity users. And then if you complete the evaluation and click submit, you should find it comes back into your inbox in about 10 minutes. So you can then file a copy to keep in your portfolio. Don't forget you get your CPD-Me portfolio as part of your FEN membership. So you can just put it straight in. And if your manager's being really lovely and giving you time back for attending lectures when it's convenient to you, then do print that off and show it to your manager so they've got evidence that you did turn up and sit through the lecture. Okay, our next lecture is on the 13th of July. That's in 2 weeks' time, and it's Dr. Barbara Needs who's going to talk to us about end-of-life dilemmas. Thank you very much, Rachel, and thank you all very much for watching.
Thank you for having me.